Welcome to the June Ultrasound Case of the Month. For anyone new to the series, these cases highlight clinical examples where ultrasound helped take better care of patients. My name is Greg Zahn. I'm an assistant professor of clinical emergency medicine. Please email me with any questions or concerns at gzahn@iu.edu. This case was seen by the resident, Dr. Jake Jacobs, one of our soon-to-graduate third years. Dr. Jacobs was working in the critical care area when he was alerted to a young adult male patient with abnormal vital signs. It was reported that the patient had been experiencing viral symptoms consisting of cough, low-grade fever, diarrhea, and sore throat. Additionally, the patient had recently lost his sense of taste and smell. The patient's biggest concern was his worsening dyspnea. At baseline, he reported running approximately 6 miles per day, yet was now getting winded with minimal activity. Vitals were obtained and displayed several abnormalities. He was tachycardic, tachypnic, slightly febrile, and hypoxic to the mid-80s on room air. His initial EKG is shown for completeness sake. With his respiratory distress and concern for COVID, a portable chest x-ray was obtained. Given his presentation, the treatment team was surprised with the seemingly normal appearance. The official radiology read was read as a small right upper lobe calcification, yet otherwise clear. As labs were pending, the case was discussed amongst the treatment team. They felt strongly that the patient clearly displayed symptoms consistent with COVID. Additionally, he had the incredibly high specificity of losing his sense of taste and smell. Yet the patient had a clear chest x-ray, which was not expected given his vital sign abnormalities. To help clarify the presentation, the team decided to perform a lung and cardiac ultrasound. They were wheeling the machine in when they were handed the following labs. They were remarkable for lymphopenia, elevated cardiac markers, and an elevated dimer. Of note, these labs were sent as part of an institutional order set on COVID-suspected patients. For anyone taking care of these sick COVID patients, elevated cardiac markers and an elevated dimer are not necessarily surprising. Yet the treatment team did not expect the cardiac markers to be elevated in such a young, previously healthy patient. With reports of cardiac involvement and cardiomyopathy in COVID patients, these labs further supported evaluation with bedside ultrasound. Here are the ultrasound images on this patient. I like starting with the peristernal long axis view because it gives a ton of information concerning the overall cardiac function. In this view, we see a peristernal long axis with a normal left ventricular ejection fraction. However, there does appear to be prominence of the right ventricle more so than we would expect in a previously healthy patient. To assist less seasoned ultrasonographers, I included this view to depict anatomy. For estimation of left ventricular ejection fraction, I look at the left ventricular chamber and the mitral valve. We can clearly see the walls of the left ventricle thicken and come towards each other with subsequent decrease in chamber size. Additionally, we see the anterior leaflet of the mitral valve hitting the interventricular septum, both indicative of a normal ejection fraction. The next view, a peristernal short axis, is obtained by simply rotating the probe 90 degrees. Here we see the thick left ventricle with a partial view of the mitral valve and papillary muscles. In this view, we see impingement of the right ventricle on the left ventricle. I outline the left ventricle and the interventricular septum to show flattening of the septum, displaying the classic D-shaped appearance. In normal physiology, the left ventricle should appear circular and without a flattened septum. Here's an apical four-chamber view. The interventricular septum is seen coming down the center of the screen. The view is great for comparison of the equality of the left and right ventricles. The normal ratio of the right to left ventricle is 0.6 to 1, yet we often teach that anything greater than a 1-to-1 ratio is abnormal. Classically, measurement for equality is performed at the mitral and tricuspid valves. This view shows enlargement of the right ventricle when compared to the left, clearly displaying greater than a 1-to-1 ratio. The lungs were analyzed next and found to be profoundly abnormal with B lines in bilateral fields. For a review of lung ultrasound, please watch the April case where COVID lung ultrasound was discussed in detail. Given the suspicion for pulmonary embolism, a DVT study was next performed. Here are representative cuts of the right femoral vein and popliteal vein. Both are compressible without evidence of clot. No DVT was identified in either leg, which was confirmed by a comprehensive study later performed in the ICU. Given the ultrasound findings, a CT was ordered. Here are two representative cuts showing extensive clot in the proximal right and left pulmonary arteries. The treatment team immediately noted these abnormalities and activated the institutional pulmonary embolism protocol. Once the CT was eventually read by radiology, it did read scattered peripheral ground glass opacities, with the differential being atypical infarcts versus COVID as well. After discussion with IR and pulmonary critical care, the patient was taken for emergent IR bilateral thrombectomy. The patient did remarkably well. After IR, he was weaned of oxygen and reported symptomatic improvement. He improved enough to be discharged on a 10A inhibitor on hospital day 2. I discussed massive pulmonary embolism in the September case and also discussed COVID lung ultrasound in the April case if anyone wants a review. The learning points for this case highlight the importance of being a bedside clinician and incorporating all the pieces of the presentation work up into the decision process. The chest x-ray and labs were somewhat unexpected and pushed the providers to do more by incorporating ultrasound. The diagnosis of pulmonary embolism would have likely been reached even without ultrasound. Yet ultrasound expedited this patient's care and helped provide evidence to quickly alter the plan to provide correct treatment and timely disposition. As any experienced clinician is aware, these patients are tenuous and can decompensate quickly. More information and a strong suspicion of the underlying pathology, even without the confirmatory CT, is incredibly helpful for guiding interventions in these patients. Thanks once again for watching. Continue using ultrasound to help take better care of your patients. As always, email me with any questions or concerns.